if we're embarking on single tooth implant treatment or other more complex implant treatments, then we need to have a basic surgical skills. So if you don't have those, then it's important to develop those skills as well. Flap design is important, and you know, in the early days we used to use more incisions like this. So this is, you know, a little envelope type flap coming back into here. I probably wouldn't go that far back these days. I come further here. Particularly, you know, a lot of the blood supply for this tissue is coming through here, and if you're grafting and you've got a bit of tension maybe on these areas, that wounds tend to dehisce there. So I tend to make incisions slightly differently these days. Papilla preserving incision, so if we want to make an incision here and preserve these, if we want to relaise a little flap, we might do a little bit of grafting there or whatever, and we'll be very careful not to dislodge these areas here. As soon as we raise those papillae, we have the increased chance of recession in those particular areas. Drilling's important, and so, you know, there's a protocol with drilling, and when we drill a little bit and we withdraw, and there's irrigation on the drills to cool the drills down. So, you know, body temperature is about 37. If we start to increase the temperature in the bone, increase 10 degrees. So if we get above 47, we tend to be, you know, cooking the bone, and that's not, you know, conducive to osseointegration. So cooling and correct instrumentation. You know, when I watch other people do surgery, often they would just drill straight in with the drills, and there's no withdrawal. So there's a heavy, you know, movement, and they want to drill all the way, and there's no cooling, there's no irrigation, and what we're doing is we're damaging the bone in those situations. Little bit of information on tooth socket healing and maturation and timing of treatment. So the healed site's the easiest to deal with. So if we've got healed bone, if you're starting out on implants, doing healed site's important. There's a lot of controversy in the literature about early placement, immediate placement. So, you know, what happens with an immediate placement is you've got an oval shaped hole where the tooth came out, and you're putting a cylindrical implant into that, and you're going to anchor that into the apical bone, and then we've got a gap, and then there's a lot of controversy about, do we graft the gap? When do you graft the gap? What do you graft the gap with, or whatever? And I think what we're coming to these days is it's better to graft the gap, and you can use, you know, autologous bone for that. You can use a xenograft for that. And Americans like to use freeze-dried bone for that, but I think the important thing is that we do put something biological in the gap. Connective tissue grafting, if that's indicated, so if we've placed an implant and we've got a gap between the labial surface of the implant and the labial gingival tissues, well, then we're probably going to need to put a connective tissue graft in that area, particularly if we've got bone in there to cover the bone. What about some proponents of placing the implants after 6 weeks? So after 6 weeks, we still haven't got good bone formation within the socket. So what we're doing then, if we're going to place an implant 6 weeks after an extraction, we've got quite good soft tissue closure, but we've got no bone. So we go in there, curate out the tissue in there, place the implant, we're going to have to graft. So the advantages of doing that is that we have a little bit more soft tissue covering that area. And just some a bit of rabbit work, we'll get past that. Implant stability. So when we place an implant, it's going to go in at a certain amount of insertion torque. And if we have above 35 Newton centimeters, then we can be confident that we can potentially load these implants immediately. But with the proviso that we need to give them information about what they can and can't do with chewing. So normally, if it's a single tooth implant, the size of the crown will be a little bit smaller than normal. It's out of occlusion. We don't want them to chew steak. We don't want to chew apples. We don't want to chew raw carrots and all these things directly on the tooth. So really, it's an aesthetic restoration rather than a functional restoration to start off with. So we will choose to load or not load based on that. If we have below 35 Newton centimeters, then we can go for the fallback position of not loading that, and we need some provisional. And then with the machine surfaced implants, we had less or a slower secondary stability with bone growth. With tie-unite surfaces and that, we have a much better improvement in terms of biological stability. So that's what these graphs here are showing. So we can, load earlier and we'll have better stability with that. So tie-unite came out in 2000, so we've now got 15 years of experience with the tie-unite implants, and again the success rates have been improved in comparison to machine surface implants, and so we can do a lot more loading. Bone levels are important, and we'll hear a lot about bone levels. This is a Brunnermark system external hex implant, and in the best conditions we always saw bone loss to the first thread because of the gap and the contamination in the gap, and then we saw better results with internal connections, and now we've got the conical connections and platform shifting, which is improving in terms of our bone levels around dental implants. And certainly, management of bone levels will get approximately in a healthy situation about 0.2 of a millimetre of bone loss per year around an implant. That would be a healthy implant, and if we've got periodontal disease or a lack of care and maintenance on these, then we'll see more marginal bone loss over the years. So what happens with roughened surface implants? We have a better adherence of the blood clot to the implant, and we'll get earlier bone healing. So these are just images on the tie-unite surface, and where we get some connective tissue forming and spreading out over the implant, and then we start to get early bone formation around that. So it's certainly good scientific evidence, and we can see here that part of these growing into the surface of the tie-unite membrane, tie-unite surface, and we've got increased quickened healing and increased bone stability around the roughened surface implants than we had with machine surface implants. And that's what lets us go ahead and then, in some cases, do early or immediate loading on things, on implants. So we just had a look at that, just reinforcing, assessment, diagnosis, treatment planning, and records. Can't hammer that enough. And then having study casts and having surgical stents like this. There's a variety of different stents that I've seen just about everything. These sort of suck down with a slightly thicker surface here, radiographic tooth in here for that. That can be removed and converted into a surgical guide. You need something that's going to sit on the surface of the teeth, not interfere. You can see that this has been cut back here, so it's not too deep around onto the gingival tissues, and so we can see what we're doing when we're instrumenting, and with that tooth removed, we converted that. So this is quite a good type of surgical stent. It's not going to rock around, it's not going to be loose, it's firm on there, it's cut away on this surface here. A little hole in the middle is only going to get a 2 millimetre drill through there. We want to have this cut away, we want to see that surface there, and we can instrument through there and we can see what we're doing, and we're not got the gingival tissues caught up in the stents. And so stents are poorly done generally, and I think this type of surgical stent is good. Macroscopic design of implants is very important. So when we're looking at implants, and you'll see, each company will have some literature on this explaining about what their implant can do. So if we're going to load things, then we want to use something that's tapered, okay? We're using a Noble replaced tapered implant. Has the potential to get us really good stability, and the Noble active implant will as well, and the Speedy Groovy and will be as well. Some of the other systems don't have implants that have good macro design for immediate placement and immediate loading. Implant length is interesting. In the early days we used to try and put the longest implants in to get good stability, or we'd go by cortical stabilisation, and Frank Renouf has done some excellent work on shorter implants. So when we're working over the nerve in the posterior mandible, we'll be happy to use shorter implants, and we have very good long-term success rates with the use of shorter implants in those zones. And in the maxilla, that's slightly different. We have slightly looser structured bone, less dense bone in the posterior maxilla, and we need to be careful about using shortened implants in those particular sites. Connections, it seems to be that it's fairly well documented now that our internal connections are giving us the best results, and the platform shifting is giving us better bone heights around the implants. And so you get a lot of information these days on internal connection and different platform shifting options. Marginal bone levels are shown to be a little bit better with the conical connection and the platform shifting. With replace, we have platform shifting with that, so there are different options. So if we have a wide platform implant, we can have it with a regular platform trilobe, and if we have a regular platform, we can have a platform shift with a narrow platform on that. Positioning of implants is important. So this is what I was talking about before. Placement is usually about 2 to 3 millimeters apical to the free gingival margin. If we're using a conical connection, we might go a millimeter deeper. Just helps us with our emergence profile on that particular implant. Generally, in the anterior zone, we're going to start our preparation towards the palate. It's going to be, if we want to have a screw access. These days, I think most people will agree that they tend to go for a screw retained restoration rather than a cement retained restoration. We want to have at least 1.5 to 2 millimeters of bone labial to our implant as well, to prevent bone loss and gingival recession in those areas. So ideally, this is what we want to see when we're placing our implant, and as I said, probably another millimeter deeper for the conical connection implant. Positioning of implants really important. If we place too labially, then we can have problems with significant resorption, and you'll see some very ugly situations where we have metal showing, and that's a disaster, and that's a situation where we're going to need to look at retreatment. So gingival tissues, we talked about this before. We've got a bit of swelling over that central incisor on the right side. Got to be a bit suspicious about bone loss perhaps. Here we go with it, just to show the implant place. We can see that there has been some scalloping and bone loss, not such of a situation that we need to be concerned too much. Looking at the crowns, and then looking at the level, and then the implant height in that particular situation. If we have this situation where we've already got gingival recession, we're going to need to look at some grafting techniques, as I said earlier, and positioning is important. This is the ideal positioning of the implant. If we're more labial than that, then we're going to get gingival recession and we're going to lose tissue. So positioning is the most important thing with these anterior implants. If we have bone loss, we need to have a way of assessing that, so having some sort of classification of idea, and that gives us a guide in terms of what kind of tissue we're going to need to replace, how much tissue we're going to need to replace, whether we're using some particulate bone or whether we're using some type of veneering, grafting is important. And when we get into full arch cases, we have some good classifications to give us a guide in terms of what we can treat. Most of us, if we're competent, could treat the ones, but when we get down to the 4s and 5s where there's a significant tissue loss, then maybe you need some special expertise to treat these particular cases. And quality of bone is important, and Laab and Zecom have a classification, so I like having classifications, and when we're assessing the radiographs we can have a look and see whether we've got a dense bone structure or more loose bone structure. So if we're putting implants into here, maybe we've got to be a little bit more concerned about our primary stability, and we may then go to a modified drilling protocol to be able to improve our primary stability, and maybe we need to consider having an extended healing period if we have issues with that. So planning with all of these cases is super important in terms of our outcomes, and then good surgical technique is important with all of that. Okay. All right. Success rates. A significant amount of work's been done on Brannemark system implants. Machine surface are now 15 years of tionite, and we have excellent results with that. And certainly moving into things like zygoma implants, we have 16 years of experience with that now, and we're looking at 98 to 100% success rates with those type of larger implants as well. So survival rates, maxilla and mandible, reasonably similar now, and that's been a change since we've got the surfaced implants like Tyenite. Made a significant difference in terms of success rates in lower density areas like the posterior maxilla. And again, looking at single tooth partials, complete bridge work. Overdentures not so good. So if you look at the overdentures of the maxilla, 73.4% is not a good area to be in, and we tend not to treatment plan people for overdentures in the maxilla because of the problems with that. But in most other areas, we can be pretty confident with our implants with very, very high success rates. Certainly with grafting, osteoinductive agents or what we can use, and there's growth factors and there's bone morphogenic proteins, and there's quite a bit of work going on with those in terms of grafting and what graft materials. I tend to keep it fairly simple, and we do some experimental work with bone morphogenic proteins, but we're still working on those in terms of protocols, and it's very expensive in this country. For small amounts of that, you're looking at $3,000, and for large amounts of bone morphogenic protein for grafting cases, we're looking up around $6,000 or more for that. So they're quite expensive issues as well. Suturing is important. I touched on that earlier. I tend to use non-resorbable sutures. The resorbable ones, we don't know when they're going to loosen, and we want to have control over the tissues, and we don't want to have wound dehiscence. So we need something that's going to last and that we can control. I tend to, with my implant cases, take the sutures out around about 10 days, but I'll look at the patient, and sometimes we'll leave them longer than that if they've got some compromise with the tissue healing, such as a diabetic or a smoker or whatever else. Side effects and complications can occur. We need to know what drugs they're taking. Certainly aspirin, I've seen some really severe bruising with patients that are on aspirin, so it's very variable. And when people are on aspirin, for example, and then typical things we'll see, it's normal to have some swelling. And if you're doing a larger case where there's been quite a bit of periodontal stripping for a grafting case, we're going to expect some swelling and bruising, and I explain that to them. Pain's not a significant issue usually with a simple implant treatment. When we do grafts, that obviously becomes more of an issue. Nerve issues are important. There's a lot of all-on-4s done these days. That technique means that the distal implants are going to be quite close to the mental foramina, and there are issues with nerve damage. And when you're looking at planning those sorts of cases, then I think you need to be looking at having some virtual planning like Noble Clinician when looking at some of those more difficult type of cases. Infections rare. Oral hygiene's important, and as well as the antibiotics. Things like cover screw exposure are important. If you have an exposed cover screw, if you leave it like that, you will get bone loss around the head of the implant. So there's two options there, either soft tissue closure over the cover screw, which can be quite difficult, or placing a healing abutment early is quite a good thing to do when we see cover screw exposure. Leaving them partially exposed, as I said, is really problematic. Just to show a couple of cases of bruising where people are on aspirin or anti-inflammatories, and then we can see some more significant bruising when people are maybe an undiagnosed von Willebrand's or something like that. So just a couple of pictures to show the kind of complications that can occur if we're not aware of what our patients are taking or what medical conditions they do have. Other complications are implant malpositioned. Well, this shouldn't happen. If you're using surgical stents and you're using good technique, then that shouldn't happen. As I said, when you've got a stent with a hole in it which is the size of a 2mm drill, and then you drill with that and then you don't use the stent again, the likelihood is your implant's not going to be in the right position. Mobility, so primary stability is important in terms of what we'll do. If you have a spinner or poor stability, then we need to look at extended healing periods or replacing that implant with a wider implant. Right, so the vast majority of complications can be avoided with adequate diagnosis and treatment planning. So really stressing that, whether we're extracting teeth or whether we're doing implants, we really need to follow through with all of those traditional things that we learn at dental school that sometimes we may, in the busy practices, avoid doing those sorts of things. And follow-up's important, so we tend to follow the patients. We want to know what's happened to them, look at them, we take sutures out, we get them back for reviews. I like to take x-rays at about 6 weeks just to check everything before I hand them back to their referring practitioner. So we really want to make sure that everything is healed up. Not seeing them for long periods of time is not good. There's also a trend with surgery for people not to follow their patients. For example, a lot of the surgeons now don't follow their wisdom tooth patients. So it's a standard of care that if you've operated on someone, done a surgical procedure, then they should have a post-operative visit where that's assessed. And so, people in busy practice are cutting corners now. Cutting corners creates problems. Cutting corners exposes you to litigation and all of those issues. So, those sorts of things can be avoided with good planning and everything. I was going to do this lead-in for you, Sam, tonight, but we've had enough, Alex, eh? No?
I'm good.
Okay.
Getting close to time.
Yeah, so maybe I'll just I put this little section in because I thought Sam was going to give a talk, but he's too tired tonight. He's exhausted. Eh? All right, so we'll just talk about platform shift. So I briefly spoke about that before. With the noble replace and trilobe. So we can go from regular platform with a narrow platform shift, or a wide platform to a regular platform shift. And when we see cases like this, you can see that it's pretty narrow space between the adjacent tooth roots. So when I do these cases, I do digital radiography when I've got my 2mm twist drill. It's very easy when you're using even using a surgical guide, where you can get slight angulation problems and you get closer to the roots and that sort of thing. So even when we think we're pretty straight, if you sit behind the patient to drill or you sit in front of the patient to drill, then you get a different perspective. So I will often shift from behind the patient to the side or the front of the patient to look at the osteotomy. And when they're close like this, I'll take intraoperative radiographs where we have an opportunity to change the direction of the implants, which I think is important. So here's this case here. We see it looks pretty good. Plenty of space at the crest of the ridge, and then it's a lot tighter just to run through the clinical photographs. And here we are taking some intraoperative radiographs, and you can see these spaces are pretty tight. Here we're getting close to there, and so I've got an opportunity to adjust that and redirect that away from that tooth root with intraoperative radiography. And we're going to choose an implant system with narrow platform that's going to be appropriate for a case like this. So we can see here we've got very good bone between the teeth, we've got good bone either side, and we're pretty tight between the adjacent tooth roots, but with good planning and with good instrumentation, we can do that. This is a case with Rick Lazar, and I do quite a lot of immediate loading with Rick, and we put the impression copings on, take an implant level impression like this. So we use a surgical stent. So Rick makes really good surgical stents. These are probably the best I've ever seen. They fit really well, and then we can use that surgical stent to take an impression. So we've got these impression copings coming out behind there, and we'll loop those together with a pattern resin at the time of surgery like this. This goes to Rick's lab, and then he'll make up the temporary. So I just put in some healing abutments for him. The way it works in my practice, I take the impressions and he puts in we get a lab made temporary, and he puts a temporary in the next day. I'm not fantastic at making chairside temporaries, so I find this is easier for us, so we can coordinate that sort of treatment. And you can see here the Rick's lab work here and some temporaries. We want these under contoured in this area so we can encourage soft tissue growth into this area. So they want to be bulbous but concave in here, and then that also helps us with our interdental papillae as well. So the next day, Rick sees the patient and inserts the temporaries, and here they are. You can see the sutures are still in place. We've got good tissue here around these implants. We've got an excess of tissue, which is what we want, because we will see some shrinkage over time. And then 1 week later, we see the patient, so the tissues are still maturating and healing of good tissues in that area there. And 2 months later, and then Rick will go to make the final crowns. And you can see with the correct contouring of the temporaries, we have very good tissues in these areas here when it comes to placing the final restorations. And here we are here just to look at the post-operative x-rays as well. So, good positioning of the implants, adequate bone, adequate soft tissue, and controlled loading. So when we put temporaries in there, this is not for them to eat anything on. We make it really plain that if you overstress the implants, you'll get micro movement during healing, you won't get integration, you'll get soft tissue formation down the length of the implants, and then a final result with those implants. And so this would be a very standard treatment that we've been doing, for over a decade now. Noble active with the conical connection, which is a very good implant. We can get very good stability with these implants. And here's the implants being placed, and this is 3 hours post-surgery. And that's up at Rick's getting, in this particular case, he did the surgery in the morning so he could load the implant in the afternoon. And then 3 months later, and then the implant final crown on that. And at tri-lobe, so now we have conical connection on the replace implants as well as, and again, impression taking technique. And then, 2 days post-surgery in this particular case, he's going to place the implants. And again, we've got pretty tight spaces between the adjacent teeth in this, so, instrumentation is really critical for these type of cases. And placement of the crowns. Okay, so the screw channel. Now, this is popular. Now, does everybody know about this and understand what this is in the audience? Is anyone who hasn't seen this before? So everybody's seen this. So this allows us, when we've got a situation where we've got poor, maybe angulation, where we've got a class 2, say div 2 situation, and we want to place an implant, and then we can redirect that by 25 degrees so we can still have a screw retained restoration. And then in the posterior we can choose to angle that. I had a case today with very poor opening, even difficult to place the healing abutments once the implants were placed. And if we use this with the angulated screw channel, we can redirect those and make it much easier to place our restorations in the posterior region. So these days, 2 important things that we're going to be considering with our implants are platform shift and conical connection. And this gives us improved treatment options and improved treatment outcomes. So we have a platform shift here. So each conical connection is automatically a platform shift. But not all of the option internal connections are so we have, these are the options here which I talked about earlier in terms of platform shift with the replace system, so we can do that. All right, so conical connection, we always have a platform shift with that. So we've got to be prepared for that. So you've got to order the implants in differently. So if you're going to use the replace system with a platform shift, we've got to make sure that we've ordered the correct implants, and so we can do that with them. So we've got those specifically designed for that. Okay, so I think I'll just finish off here and say that there's a lot of literature now coming out on these particular options, and I think they're very good options to be looking at and considering as we move forward with our implant treatments. All right, so I'll finish up there, Alex, and thank you very much for everybody's attention this evening.